Alrighty, time for another video where I read a piece of legislation. And what I'm going to read this time is Senator Sanders' Medicare for All bill. I've talked about this topic in the past, but I figured it would be a good idea to actually critique it, like read the bill like I do with some other bills, and give my critiques. This bill is pretty long, just warning you now, this video is going to take a while. So let's not dilly-dally. So this is the Senate Bill 1129, introduced by Senator Sanders, and it is a bill to establish a Medicare for All national health insurance program. The short title, this act may be cited as the Medicare for All Act of 2019, and I'll just read through the table of contents, and man, I have an itch in my nose. It's really annoying the shit out of me. So Section 1 is the short title, table of contents. Section 101 is the establishment of the Universal Medicare Program. 102, Universal Entitlement. 103, Freedom of Choice. 104, Non-Discrimination. 105, Enrollment. 106, Effective Date of Benefits. 107, Prohibition against Duplicate Coverage. Okay. Oh, and this is all under Title 1, Establishment of the Universal Medicare Program, Universal Entitlement, Enrollment. Title 2, Comprehensive Benefits, including preventive benefits and benefits for long-term care. Section 201 is Comprehensive Benefits. Section 202 is No Cost Sharing. 203, Exclusions and Limitations. 204, Coverage of institutional long-term care services under Medicaid. 205, Prohibiting recovery of correctly paid Medicaid benefits. 206, State Standards. And we have Title 3, which is Provider Participation. 301, Section 301 is Provider Participation and Standards. 302, Qualifications for Providers. 303, Use of Private Contracts. Sorry, not contacts. God, you'd think I'd need reading glasses or something. Title 4, Administration. Subtitle A, General Admissions Administration Provisions. Section 401 is Administration, 402 Consultation, 403 Regional Administration, 403 Beneficiary Ombudsman, 405 Complementary Contact of Related Health Programs. Subtitle B, Control over Fraud and Abuse. Section 411, Application of Federal Sanctions to all fraud and abuse under Universal Medicare Program. Title 5, Quality Assessment. Section 501, Quality Standards. 502, Addressing Healthcare Disparities. Title 6, Health Budget, Payments, Cost Containment Measures. Subtitle A, Budgeting. Section 601, National Health Budget. Subtitle B, Payments to Providers. Section 611, Payments to institutional and individual providers. 612, Ensuring accurate valuation of services under the Medicare Physician Fee Schedule. Not free fee. 613, Office of Primary Health Care. 614, Payments for prescription drugs and approved devices and equipment. Title 7, Universal Medicare Trust Fund. And Section 701 is the Universal Medicare Trust Fund. Title 8, Informing Amendments to the Employee Retirement Income Security Act of 1974. Section 801, Prohibition of Employee Benefits duplicative of benefits under the Universal Medicare Program. Coordination in case of workers' compensation. 802, Repeal of continuation coverage requirements under ERISA and certain other requirements relating to group health plans. Section 803, Effective date of title. Title 9, Additional Conforming Amendments. Section 901, Relationship to existing federal health programs. Section 902, Sunset of provisions related to state exchanges. Title 10, Transition. Subtitle A, Transitional Medicare Buy-in Option and Transitional Public Option. Section 1001, Lowering Medicare Age. Section 1002, Establishment of the Medicare Transition Plan. Subtitle B, Transitional Medicare Reforms. Section 1011, Medicare Protection Against High Out-of-Pocket Expenditures for Fee-for-Service Benefits and Elimination of Parts Alpha and Bravo deductibles. Section 1012, Reduction in Medicare Part Delta Annual Out-of-Pocket Threshold and Elimination of Cost Sharing above that threshold. Section 1013, Coverage of Dental and Vision Services and Hearing Aids and Examinations under Medicare Part B. Section 1014, eliminating the 24-month waiting period for Medicare coverages for individuals with disabilities. Section 1015, guaranteed issue of Medigap policies. Subtitle C, private health insurance availability during transitional period. Section 1021, continuity of care. Title 11, miscellaneous. 1011, Section 1011, updating resource limits for supplemental security income eligibility. And Section 1102, definitions. So that is the table of contents, and we're already 5 minutes into the video. Buckle in. Just maybe cook dinner or something while you listen to this. Okay, so under Title 1, establishment of the Universal Medicare Program, Universal Entitlement Enrollment. Section 101 just says, okay, this is what this does. Section 102, Universal Entitlement. In general, every individual who is a resident of the United States entitled to benefits for healthcare services under this Act. The Secretary shall promulgate a rule that provides criteria for determining residency for eligibility purposes under this Act. Let's see, Bravo says, treatment of other individuals. The Secretary, 1, may make eligible for benefits for healthcare services under this Act other individuals not described in subsection Alpha, and regulate their eligibility to ensure that every person in the United States has access to health care, and 2, shall promulgate a rule consistent with federal immigration laws to prevent an individual from traveling to the United States for the sole purpose of obtaining health care services provided under this Act. So, yeah, I mean, this makes sense, it's, what was that, was it a congressman or some jackoff who, was bitching about, no, we shouldn't have Medicare for all, and then went to Canada for free health care. But yeah, I mean, my position is if we're going to have a universal health care system, then anybody that works here contributes to the economy should be entitled to those rights, because they're paying taxes. So if they're paying taxes, then they're paying into the system, and then therefore they should get the coverage as well. And then, not just people that come here for the sole purpose of, I want to go to America to get healed because it's free there. Section 103, freedom of choice. Any individual entitled to benefits under this Act may obtain health services from any institution, agency, or individual qualified to participate under this Act. So, doesn't matter who you go to, as long as it's a doctor, they'll get paid, and you'll get treated. Section 104, non-discrimination. Alpha, in general, no person shall, on the basis of race, color, national origin, age, disability, or sex, including sex stereotyping, gender identity, sexual orientation, and pregnancy related to related medical conditions, including determination of pregnancy, be excluded from participation in, be denied benefits of, or be subject to discrimination by any participating provider as defined in Section 301, or any entity conducting, administering, or funding a health program or activity, including context of insurance pursuant to this Act. So, don't discriminate. Bravo, claims of discrimination. 1. In general, the Secretary shall establish a procedure for adjudication of administrative complaints alleging a violation of subsection Alpha. 2. Jurisdiction. Any person aggrieved by a violation of subsection Alpha by a covered entity may file suit in District Court of the United States having jurisdiction of the parties. 3. Damages. If a court finds a violation of subsection Alpha, the court may grant compensatory and punitive damages, declaratory relief, injunctive relief, attorney's fees and costs, or other relief as appropriate. So if you get discriminated against, then the government's got to pay for everything. And you prove it in court, then the government's got to pay for everything that you had to do to pursue that discrimination case. Ow. Oh, fuck. I keep forgetting I have rods in my spine. Okay, Section 105, enrollment. 1 second, I'm going to get some water. Okay. Yep, gonna need a lot of this shit. Okay. Section 105, enrollment. Alpha, in general, the Secretary shall provide a mechanism for the enrollment of individuals eligible for benefits under this Act. The mechanism shall, 1. Include a process for the automatic enrollment of individuals at the time of birth in the United States or upon establishment of residency in the United States. 2. Provide for the enrollment as of the date described in Section 106 of all individuals who are eligible to be enrolled as of such date. And 3. Include a process for the enrollment of individuals made eligible for healthcare services under Section 102 Bravo, which is the people who aren't really citizens, but they work here. What I was talking, that's what I was talking about before. So, yeah. So this is. Oh, let me just read Bravo of this part. Subsection Bravo: issuance of universal Medicare cards in conjunction with an individual's enrollment for benefits under this Act. The Secretary shall provide for the issuance of universal Medicare. A universal Medicare card that shall be used for purposes of identification and processing of claims for benefits under this program. The card shall not include an individual's Social Security number. So it's another government identification card. Fine. Whatever. Everybody gets enrolled automatically to the universal, to the Medicare for All program. That's basically what this section is saying. Section 106, effective date of benefits. Alpha, in general, except as provided in subsection Bravo, benefits shall be available under this Act for items and services furnished on January 1st of the 4th calendar year that begins after the date of the enactment of this Act. So, if this gets voted in, then 4 years later, everything's going to be available to people, and I'm going to get into that at the end of the video. Bravo, coverage for children. 1. In general, for any eligible individual who has not yet attained the age of 19, benefits shall first be available under this Act for items and services furnished on January 1 of the 1st calendar year that begins after the date of the enactment of this Act. 2. Option to continue in other coverage during transition period. Any person who is eligible to receive benefits as described in paragraph 1 may opt to maintain any coverage described in Section 901, private health insurance coverage, or coverage offered pursuant to Subtitle Alpha of Title 10, including amendments made by subtitle, until the effective date described in subsection Alpha. So, while during the transition period, you can still use your other insurance, and kids will be enrolled the beginning of the year after this gets voted in, if it gets voted in. Section 107, prohibition against duplicating coverage. Alpha, in general, beginning on the effective date described in Section 106 Alpha, shall be unlawful for 1. A private health insurance to sell health insurance coverage that duplicates the benefits provided under this Act, or 2. An employer to provide benefits for an employee, former employee, or dependents of an employee or former employee that duplicates benefits provided under this Act. Bravo, construction. Nothing in this Act shall be construed as prohibiting the sale of health insurance coverage for any individual benefits not covered by this Act, including additional benefits that an employer may provide to employees or their dependents, or to former employees or their dependents. So what this is saying is that nobody can sell you health insurance that is going to give you the same coverage that you're already going to get by the government. Why? Part of that is so that you don't get ripped off. You're not paying extra money for nothing. Well, yeah, I mean that's mostly why. There are ways that can swing both. There are ways that can be used both ways, both beneficial and detrimental. Well, let me talk about that now before I forget. Sorry, don't forget. So what this says is that the coverage that is going to be provided by this bill is you have to get through government services. You're not going to be able to get through other means. Now, on its face, that seems kind of like a bad thing, because now you have to Well, I mean, it's a good thing and a bad thing. Um, but the thing is that you're gonna have to go through the government. Like I said, you're gonna have to go through the government system for your basic health care. Um, we'll see in the rest of this bill um, how that if it's laid out even more. Um, why it would be a good thing? Well, it's I've said I want a socialized healthcare system, a completely socialized healthcare system, and but at the same time, I would want to ensure in the legislation that that socialized healthcare system is adequately funded. So something like this, which on its face may seem like a bad thing, it's also helped to ensure that this kind of system would be adequately funded because people, if they're not getting their health care, someone's not getting voted in again for another term. You know, it's kind of a smart legislation in that aspect. Okay, Title II, comprehensive benefits, including preventive benefits and benefits for long-term care. Section 201, comprehensive benefits. Alpha, in general, subject to other provisions of this title and Titles 4 through 9, individuals enrolled for benefits under this Act are entitled to have payment made by the Secretary to have an eligible provider for the following items and services, if medically necessary, or appropriate for the maintenance of health or for the diagnosis, treatment, or rehabilitation of a health condition. 1. Hospital services, including inpatient and outpatient hospital care, including 24-hour-a-day emergency service and inpatient prescription drugs. 2. Ambulatory patient services. 3. Primary and preventive services, including chronic disease management. 4. Prescription drugs, medical devices, biological products, including outpatient and prescription drugs, medical devices, and biological products. 5. Mental health and substance abuse treatment services, including inpatient care. 6. Laboratory and diagnostic services. 7. Comprehensive reproductive, maternity, and newborn care. 8. Pediatrics, including early and periodic screening, diagnostic, and treatment services as defined in Section 1905, Romeo of the Social Security Act, 42 U.S.C. 1336 Delta Romeo. 9. Oral health, audiology, and vision services. 10. Short-term rehabilitative and habilitative services and devices. 11. Emergency services and transportation. 12. Necessary transportation to receive health care services for individuals with disabilities and low-income individuals. 13. Home and community-based long-term services and supports to be provided in accordance with the requirements for home and community-based settings under sections 441.530 and 441.710 of Title 42 Code of Federal Regulations, including, here's where we get to a lot of other legislation, Alpha, services described in paragraph 7, 8, 13, 19, and 24 in section 1905 Alpha of the Social Security Act, 42 U.S.C. 1396 Delta Alpha. Bravo, home and community-based services described in subsection Charlie 4 Bravo of section 1915 of the Social Security Act, including habilitation services defined in section Charlie 5 of such section. Charlie, self-directed home and community-based services as described in subsection India of section 1915 of the Social Security Act. Delta, self-directed personal assistance services as defined in subsection Juliet 4 Alpha of section 1915 of the Social Security Act. And Echo, home and community-based attendant services and supports described in the definition in the subsection Kilo of section 1915 of the Social Security Act. So this whole section here is just listing stuff that people will receive, and to make sure that, and it's pointing out that there's other legislation to make sure people are receiving certain things, if they're on Social Security disability and whatnot. So it's pointing out to that legislation. Bravo, revision and adjustment. The Secretary shall, on a regular basis, evaluate whether the benefits package should be improved or adjusted to promote the health of beneficiaries, account for changes in medical practice or new information from the medical research, or respond to other relevant developments in health science, and shall make recommendations to Congress regarding any such improvements or adjustments. Okay? Make sure everything's working. This is So this is a double-edged sword thing, because you can get some fuck off in there and says, you know what, I think people are getting too much. They shouldn't be getting so much. Charlie, complementary and integrative medicine. 1. In general, carrying out subsection Bravo, the Secretary shall consult with the persons described in paragraph 1 with respect to Alpha, identifying specific complementary and integrative medicine practices that, on the basis of research findings or promising clinical interventions, are appropriate to include in the benefits package, and Bravo, identifying barriers to the effective provisions and integration of such practices in the discovery of healthcare, and identifying mechanisms for overcoming such barriers. So this is kind of important. So it's making sure that your healthcare, your treatment options aren't so limited. Basically, it's saying if it works, it's an option for you. If it's been proven to work, if it comes out, if it's so. It also, well, it does have the point here. So if it looks like it's promising, like maybe it's a new thing and people are trying it, and so far the results have been good from it, then you can try that also. 2. Consultation. In accordance with paragraph 1, the Secretary shall consult with Alpha, the Director of the National Center for Complementary and Integrative Health, Bravo, the Commissioner of Food and Drugs, Charlie, institutions of higher education, private research institutes, and individual researchers with extensive expertise in complementary and integrative medicine and the integration of such practices into the delivery of health care. Delta, nationally recognized providers of complementary and integrative medicine, and Echo, other such officials, entities, individuals, and with expertise on complementary and integrative medicines as the Secretary deems appropriate. So this is just saying that who to talk to make adjustments on like treatments and everything, or the benefits package as well. Delta, states may provide additional benefits. Oh, that's nice. Individual states may provide additional benefits for residents of such states at the expense of the state. Oh, that's very good. So we can see which state really hates its people by not providing them additional benefits. I like that. Section 202, no cost sharing. Alpha, in general, the Secretary shall ensure that no cost sharing, including deductibles, co-insurance, co-payments, or similar charges, to be imposed on an individual for any benefits under this Act except as described in subsection Bravo. So let's see what those exceptions are. Bravo, exceptions. Secretary may set a cost-sharing schedule for prescription drugs and biological products, 1, provided that Alpha, such schedule is evidence-based and encourages the use of generic drugs. Bravo, such cost-sharing does not apply to preventive drugs. Charlie, such cost-sharing does not exceed $200 a month annually per individual, adjusted annually for inflation. And Delta, such cost-sharing is not imposed on individuals with household income equal to or below 200% of the poverty line for a family of the size involved. And 2, under which the Secretary may exempt brand name drugs from consideration determining whether an individual has reached any out-of-pocket limit if a generic version of drug is available. Okay, so let's unravel this really quick. So this is some pretty good stuff in here. One thing that's good in here is the adjusted annually for inflation. I don't like dealing with hard numbers in legislation because things change. You know, we have inflation. I would say inflation and deflation, but let's face it, we're always getting fucked with inflation. So what this is saying, what this section is basically saying, is that you don't pay for anything. All right, you go there, you're not going to spend an extra dime out of your pocket, no copay or anything like that. You're only going to pay for certain drugs if there's a generic version available. So if you want like this prescription drug and you want this certain one from this manufacturer, you're going to pay for a little bit out. You're going to pay a little bit out of your pocket if you can just turn around and get the same result from a generic version instead. Let's see. Charlie, no balance billing. notwithstanding contracts in accordance with Section 303, no provider may impose a charge to an enrolled individual for covered services for which benefits are provided under this Act. So you don't get those if you get a medical bill in the mail and it has a fee on it. The only thing they can charge you for is something that you're not being covered by already. Section 203, exclusions and limitations. Alpha, in general, benefits for services are not available under this Act unless the services meet the standards specified in Section 201 Alpha as defined by the Secretary. Bravo, treatment of experimental services and drugs. 1. In general, applying subsection Alpha, the Secretary shall make national coverage determinations with respect to services that are experimental in nature. Such determinations shall be consistent with the national coverage determination process as defined in Section 1869 Foxtrot 1 Bravo of the Social Security Act 42 U.S.C. 1395 F Foxtrot 1 Bravo. 2. Appeals process. The Secretary shall establish a process by which individuals can appeal coverage decisions. This process shall, as much as is feasible, follow processes for appeals under the Medicare program described in Section 1869 of the Social Security Act 42 U.S.C. 1935 Foxtrot. So this is the part talking about considering newer experimental procedures and medications. And Charlie, application of practice guidelines. In the case of services for which the Department of Health and Human Services has recognized a national practice guideline, the services are considered to meet the standards specified in Section 201 Alpha if they have been provided in accordance with such guideline. For purposes of this subsection, the service shall be considered to have been provided in accordance with a practice guideline if the healthcare provider providing the service exercised appropriate professional discretion to deviate from the guideline in a manner authorized or anticipated by the guideline. So this is more of if they're doing something that's kind of like out of the ordinary, as long as they're following like a set of rules, they don't have to do the same thing. It doesn't have to be like cookie cutter for everybody. Someone may have a situation where there's a specific need. As long as that specific need is met within the rules, okay. Section 204, coverage of institutional and long-term care services under Medicaid. Title 19 of the Social Security Act, 42 U.S.C. 1936 Sequitur, is amended by inserting the following section after Section 1946. Okay, so here's what's all going to get, so it's basically inserting a new section. So state plan for providing institutional long care services, Section 1947 Alpha in general, for quarters beginning on or after the date, that's quarter year, which benefits are first available under Section 106 Alpha of the Medicare for All Act of 2019, notwithstanding any other provision of this title. 1. The state plan for medical assistance shall provide for making medical assistance available for services that are institutional long-term care services in a manner consistent with this section. And 2. No payment to a state shall be made under this title with respect to expenditures incurred by the state in providing medical assistance on or after such date to services that are not Alpha, institutional long-term care services, or Bravo, other services for which benefits are not available under the Medicare for All Act of 2019, which are furnished under a state plan for medical assistance, which provided for medical assistance and for such services on September 1st, 2018. So this is basically just saying state pays for things, government pays them back. But they might miss others that are not. Right. No payments are made to a state under this title was incurred by the state providing medical. Okay. So the state paying for long care services other services. Okay, so yeah, this is basically saying like all the long care stuff, the state will pay for, and then the government will pay them back. Bravo, institutional long-term care services defined. In this section, the term institutional long-term care services means the following. 1. Nursing facilities for individuals 21 years of age or over, described in subparagraph alpha of section 1905 alpha 4. This again talking about the Social Security Act. 2. Inpatient services for individuals 65 years of age or over, provided in an institution for mental disease, described as section 1905 alpha 14 of the Social Security Act. 3. Intermediate care facilities, described as section 1905 alpha 15. 4. Inpatient psychiatric hospital services for individuals under age of 21, is described in section 1905 alpha 16. 5. Nursing facilities services, described in section 1905 alpha 29. So these are all just services that are talked about in the Social Security Act to be provided. Charlie, maintenance of effort. 1. Eligibility standards. Alpha, in general, beginning on the date described in subsection alpha, no payment may be made under section 1903 with respect to medical assistance provided under the state plan for medical assistance if the state adopts income, resource, or other resources or other standards or methodologies for purposes of determining an individual's eligibility for medical assistance under the state plan that are more restrictive than those applied as of January 1st, 2019. So if the state decides to be more restrictive, then to say, okay, you can't have this even though everybody else in the country is getting it, then the state's not getting reimbursed. Bravo, indexing of amounts of income and resource standards. In determining whether the state has adopted income or resource standards that are more restrictive than standards which applied as of January 1st, 2019, the Secretary shall deem the amount of any such standard that was applied as of such date to be increased by the percentage increased in the medical care component of the Consumer Price Index for all urban consumers, U.S. city average, from September 2018 to September of fiscal year for which the Secretary is making such determination. So this is just saying, this is just laying out the basis for what states can set as their standards. 2. Expenditures. Alpha, in general, for each fiscal year or portion of fiscal year that occurs during the period that begins on the first day of the first fiscal quarter that begins on or after the date on which benefits are first available under Section 106 Alpha of the Medicare for All Act of 2019, as a condition of receiving payments under Section 1903 Alpha. Again, this is still stuff to be inserted into the Social Security Act. The state shall make expenditures for medical assistance for services that are institutional long-term care services, an amount that is not less than the expenditure floor determined for the state and fiscal year or portion of a fiscal year under subparagraph Bravo. And Bravo, the expenditure floor. 1. In general, for each fiscal year or portion of fiscal year described in subparagraph Alpha, the Secretary shall determine for each state expenditure floor that shall be equal to 1. The amount of the state's expenditure for fiscal year 2018 on medical assistance for long-term institutional long-term care services increased by 2, the growth factor determined under subclause 2, which is coming up. So 2, the growth factor for each fiscal year or portion of a fiscal year described in subparagraph Alpha, the Secretary shall, not later than September 1st of the fiscal year preceding such fiscal year or portion of fiscal year, determine the growth factor for each state that take into account 1, the percentage increase in healthcare costs in the state, 2, the total amount expended by the state for the previous fiscal year on medical assistance for institutional long-term care services, 3, the increase, if any, in the total population of the state from July 2018 to July of fiscal year preceding the fiscal year involved, 4, the increase, if any, the population of the individuals age 65 and older of the state from July 2018 to July of the fiscal year preceding the fiscal year involved, and 5, the decrease in any population state that requires medical assistance for institutional long-term care services that is attributed to the availability of coverage for services described in Section 201 Alpha 13 of the Medicare for All Act of 2019. So, what this is saying is that there's a minimum amount that a state has to spend. That minimum amount changes based on the population cost, how much money was spent, or not the population changes, the medical needs changes, and the expenditure changes. 3. The proration rule. Any amount determined under the subparagraph for a portion of a fiscal year shall be prorated based on the length of such portion of a fiscal year relative to complete fiscal year. So this is saying, prorating. So if you're only covering expense for part of a year, you figure out what the same expense would be for a whole year, and that's what you base it off of. You do a proportion. Okay, so all that was for the maintenance of effort and the expenditures. And then we go to Delta, non-application of certain requirements. Beginning on the date described in subsection alpha of any provision of this title requiring a state plan for medical assistance to make available medical assistance for services that are not institutional long-term care services or services described in section 901 alpha 3 alpha 2 of the Medicare for All Act of 2019 shall have no effect. So what this is saying is that things in here are going to be overwritten by the Medicare. Things in the Social Security Act will be overwritten by the Medicare for All Act, so that states don't have to make a plan. So what it's saying is that the states only need to plan for what's being described here as the long-term institutional care services. All right. Oh, that was a long one. That was a long section. And that again, that was all amending the Social Security Act. So, Section 205, prohibiting recovery of correctly paid medical benefits or Medicaid benefits. Section 1917 of the Social Security Act 42 U.S.C. 1396 Papa is amended. 1. By amending the section, by amending subsection alpha to read as follows: no lien may be imposed against the property of any individual prior to his death on account of medical assistance paid or to be paid on his behalf under the state plan, except pursuant to the judgment of a court on account of benefits incorrectly paid on behalf of such individual. And 2. By amending subsection Bravo to read as follows: no adjustment or recovery of medical assistance correctly paid on behalf of an individual under the state plan may be made. So basically, you can't. What this is saying is the state can't retroactively say, you know what, we paid for these medical benefits and we decided we don't want to pay them anymore, so we want that money back. Now, if they incorrectly pay you too much, then they're entitled to the money back, obviously. But this is preventing them from saying, like a change of governorship or of the legislature in that state, from going around saying, you know what, we don't think that we should have paid people for these health benefits in the past. We're gonna get that money back. Section 206, State Standards. In general, nothing in this Act shall prohibit states from setting additional standards with respect to eligibility, benefits, and minimum provider standards consistent with the purposes of this Act, provided that such standards do not restrict eligibility or reduce access to benefits or services. So, that's kind of interestingly worded, because they're saying, okay, the states can have additional standards and eligibility standards, but not as long as they go against what's said here. I'd be interested in seeing what kind of fuckery people do to get around that and try to restrict access to people, through the individual states. So yeah, that's interesting. Bravo, restrictions on providers. With respect to any individual or entity certified to provide services covered under Section 201 Alpha 7, a state may not prohibit an individual entity from participating in the program under this Act, for reasons other than the ability of the for reasons other than the ability of the individual or entity to provide services. So, the state can't say, you know what, so here's a good example. State can't say, you know what, we don't like abortions and we know that you've done abortions, so we're not going to allow you to practice and get paid in this through the Medicare for All program. So they won't be able to say stuff like that. As long as somebody's a doctor, they can treat you and they can get paid through this act. Again, that's if this act passes. Okay, so Title III, we are now, looks like a little under a third through the document. Provider participation. Section 301, provider participation and standards. Alpha, in general, any individual or other entity furnishing any covered service under this act is not a qualified providing unless the individual or entity, 1, is a qualified provider of the services under Section 302, which is the next section, 2, has filed with the Secretary a participation agreement described in subsection Bravo, and 3, meets, as applicable, such other qualifications and conditions with respect to a provider of services under Title 18 of the Social Security Act as described in Section 1866 of the Social Security Act, 42 U.S.C. 1395 double Charlie. All right. So again, so if you want to be a doctor or a hospital or a clinic and be able to treat people that are being covered by Medicare for All, you have to obviously be qualified, and you also have to register and agree, make an agreement. Which, okay, here we go. Bravo, requirements in participation agreement, because I was just about to ask what would be in that agreement. 1, in general, a participation agreement described in this subsection between secretary and provider shall provide at least for the following. Alpha, services to eligible persons will be furnished by the provider without discrimination in accordance with Section 104 Alpha. Nothing in this subparagraph shall be construed as requiring the provision of a type or class of services that are outside the scope of the provider's normal practice. Okay, so you can't have a radiologist all of a sudden be a general practitioner. Bravo, no charge will be made to any enrolled individual for any covered services other than for payment authorized by this act. And again, we talked about before that the act is going to cover basically everything, and if there's anything they don't get that doesn't get covered for the act, that's the only thing that they can charge you for. So what are things like this? Like unnecessary plastic surgery. So if you go to a doctor that if you go to a plastic surgeon, there's recovery plastic surgery for, like, if you've been in an accident, you've been deformed, that kind of stuff. That'll probably be recovered under Medicare for All bill. But for people like me who are just born ugly and want plastic surgery to, make themselves more appealing, personally, I don't know why. I really enjoy the fact that I'm ugly. It keeps all the stupids away. But whatever. So something like that wouldn't be covered under Medicare for All. I'm assuming, at least. But to give you, I wanted to use those examples to give you the distinction. So if I decide, I want to have a face that everybody would love, I would have to pay for that out of pocket, even if the place is registered to serve those that are what's it called, treating people under Medicare for All. Okay, Charlie, the provider agrees to furnish such information as may be reasonably required by the Secretary in accordance with uniform reporting standards established under Section 401 Bravo 1 for 1. Quality review by designated entities. 2. Making payments under this Act, including examination of records as may be necessary for the verification of information on which such payments are based. 3. Statistical or other studies required for the implementation of this Act. And 4. Such other purposes as the Secretary may specify. So this is basically that they got to turn over information, which is obvious because they want to get paid. And 2, it's the aggregating information, which, let's see, you can aggregate information for research purposes because, again, the part of this bill talks about what different practices can be used in treatment. Okay, Delta. In the case of a provider that is not an individual, the provider agrees not to employ or use for the provision of health services or any individual or other provider that has had a participation agreement under this subsection terminated for cause. So what they're saying is, okay, let's say I'm a doctor working under Medicare for All, and I did some fuckery, and now I can't treat any patients under Medicare for All. Well, I can't just go to this hospital and say, you know what, I'll just work there because they have a license to work on, they have an agreement to work under Medicare for All. No, they won't be able to hire you. Okay, Echo. In the case of a provider paid under a fee for service basis, the provider agrees to submit bill and any required supporting document relating to the provision of covered services within 30 days after the date of providing such services. That's just billing, time for billing. Okay, 2, termination of the participation agreement. Alpha, in general, who would have thought the English language would be so hard, right? Participation agreements may be terminated with appropriate notice, 1, by the Secretary for failure to meet the requirements of this Act, or 2, by a provider. So, either one. And the doctor can just say, you know what, I'm done with this shit, you know, for whatever reason. Okay, Bravo, termination process. Providers shall be provided notice and a reasonable opportunity to correct deficiencies before the Secretary terminates an agreement unless a more immediate termination is required for public safety or similar reasons. And this is the fuckery I was talking about before. Charlie, provider protections. 1, prohibition. The Secretary may not terminate a participation agreement or in any way discriminate against or cause to be discriminated against any covered provider, authorized representative of the provider on account of such provider or representative, 1, providing or causing to be provided or being about to provide or cause to be provided to the provider, the federal government, or the Attorney General of a state information regarding relating to any violation of or act of omission that the provider or representative reasonably believes to be a violation of any provision of this title or an amendment made by this title. Wow, that was a word salad, wasn't it? So let me read these other 2. 2, testifying, and you'll get a better idea what to say. 2, testifying or about to testify in a proceeding concerning such violation. 3, assistance in participating or being about to assist or participate in such a proceeding. Or 4, objecting to or refusing to participate in any activity, policy, practice, or assigned task that the provider or representative reasonably believes to be in violation of any provision of this Act, including any amendment made by this Act, or any order, rule, regulation, standard, or ban under this Act, including any amendment made to be in this Act. So, what this whole word salad that I just read is if they're told to do something that's violating the Act, and they say no, fuck off, or no, and then they're going to go to court and say, hey, these people are trying to fuck with the healthcare system here. So they can't do any reprisals, basically. This is like, hey, something's wrong. Some guy says, hey, I'm a doctor and something's wrong with the system. No, the secretary can't turn around and say, oh, well, you want to say something's wrong with the system? Well, I'm going to terminate your ability to be a healthcare provider for Medicare patients. So the prohibited from doing that. Okay, 2, complaint procedure. A provider or representative who believes that he or she has been discriminated against in violation of this section may seek relief in accordance with the procedures, notifications, burden of proof, remedies, and statutes and limitations set forth in Section 2087 Bravo of Title 15 United States Code. This is just how to register a complaint. Okay. Section 302, qualifications for providers. So if you want to be a provider, this is what you need to have. Alpha, in general, a healthcare provider is considered to be qualified to provide covered services if the provider is licensed or certified and meets 1, all the requirements of state law to provide such services, and 2, applicable requirements of federal law to provide such services. So that's pretty straightforward. Bravo, minimum provider standards. 1. In general, the Secretary shall establish, evaluate, and update national minimum standards to ensure the quality of services under this Act and to monitor efforts by states to ensure the quality of such services. A state may also establish additional minimum standards for which providers shall meet with respect to services provided in each state. This is something that I want to have a couple words on, and it's going to be at the end of the video. 2. National minimum standards. This whole section here, basically. 2. National minimum standards. The national minimum standards under paragraph 1 shall be established for institutional providers of services and individual healthcare practitioners. Except as the Secretary may specify, in order to carry out this act, a hospital, skilled nursing facility, or other institutional provider of services shall meet standards for such a provider under the Medicare program under Title 18 of the Social Security Act, 42 U.S.C. 1395, et sequitur. Such standards also may include, where appropriate, elements relating to alpha, adequacy and quality of facilities. Bravo, training and competence of personnel, including continuing education requirements. Charlie, comprehensiveness of service. Delta, continuity of service. Echo, patient satisfaction, including waiting time and access to services. And Foxtrot, performance standards, including organization, facilities, structure of services, efficiency of operation, outcome and palliation, improvement of health, stabilization, cure, or rehabilitation. Okay, so this is saying establish all this minimum guideline stuff. Okay, 3. Transition in application. If the Secretary provides for additional requirements for providers under this subsection, any such additional requirement shall be implemented in a manner that provides for a reasonable period during which a previously qualified provider is permitted to meet such an additional requirement. 4. Ability to provide services. With respect to any entity or provider certified to provide services described in Section 201 Alpha 7, the Secretary may not prohibit such entity or provider from participating for reasons other than its ability to provide such services. Okay, so this again. So well, not really again, but what this is saying is like, hey, it's another non-discrimination thing. It's if somebody can do the job and they're qualified, then they can do the job. The Secretary can't exclude them for whatever reason. Just say, oh, you know what, I know you and I don't like you. Fuck off, I'm not letting you in this program. Okay, Section 303, use of private contracts. In general, Alpha, in general, subject to the provisions of this subsection, nothing in this act shall prohibit an institutional or individual presider from entering into a private contract with an enrolled individual for any item or service, 1, for which no claim or payment is to be submitted under this act, and 2, for which the provider receives, Alpha, no reimbursement under this act directly or on a capitated basis, and Bravo, receives no amount for such item or service from an organization which receives reimbursement for such items or service under this act directly on a capitated basis. So you can. So what it's saying is you can get external insurance just as long as it's not for stuff that's covered and being paid for by this act. Bravo, beneficiary protections. 1. In general, subsection Alpha shall not apply to any contract unless Alpha, the contract is in writing and is signed by the beneficiary before any item of service is provided pursuant to the contract. So signed it before. Bravo, the contract contains items described in paragraph 2. And Charlie, which is paragraph 2 is coming up. In Charlie, the contract is not entered into at a time when the beneficiary is facing an emergency health care situation. Okay, so, hey, you're about to die, sign this contract and I'll heal you. And, yeah. Okay, 2, items required to be included in contract. Any contract to provide items and services to which subsection Alpha applies shall clearly indicate to the beneficiary that by signing such a contract, the beneficiary, Alpha, agrees not to submit a claim or to request that the provider submit a claim under this act for such items or services, even if such items and services are otherwise covered by this act. Oh, that almost sounds like that you can get coverage instead of Medicare. Bravo, agrees to be responsible, whether through insurance offered under this section 107 Bravo or otherwise, for payments of such items and services and understands that no reimbursement will be provided under this act for such items and services. Charlie acknowledges that no limits under this act apply to amounts that may be charged for such items and services. Delta, if the provider is a non-participating provider, acknowledges that the beneficiary has the right to such items or services provided by or other providers for whom payment would be made under this act. And Echo acknowledges that the provider is providing services outside the scope of the program under this act. Okay, so you can't. All right. Because for a second there, it was seeming like that you could just basically opt out of the Medicare for All program and just go with private insurance. Well, okay. I have to reread that. It's either saying either I misread that, and what it's saying is that you can have insurance, and not be covered by Medicare for All, and you have the insurance pay for it and not the Medicare for All, or you can't have insurance. So basically, it prevents a person from like double dipping, right? You get insurance pays for it. Let's say the insurance pays less than Medicare for All would pay, and then the person would get the money from the Medicare for All. That's one way of looking at that. But no, it seems more like that you can't get insurance that provides the same thing that the Medicare for All would cover because you're already covered by the Medicare for All. But you can get insurance for things that are not covered by Medicare for All, which is you have those already with Medicare, like what is it, Medicare Advantage or some shit like that. Not Advantage. I don't know. I don't fucking watch TV, so I'm pretty sure you've seen those commercials. Okay, Charlie, provider requirements. 1. In general, subsection alpha shall not apply to any contract unless an affidavit described in paragraph 2 is in effect during the period any item of services to be provided pursuant to the contract. I'm just still thinking about it. No, because I'm thinking about what I read before. So no, you can't have insurance that covers anything that Medicare All provides you with because you're already covered by the Medicare for All. But you can get insurance for stuff that's on top of that. Okay, so yeah. Okay, so back to this. So it shall not apply to any contract unless the affidavit, blah, blah, blah. So 2, the affidavit. An affidavit is described in this subparagraph shall, alpha, identify the practitioner and be signed by such practitioner. Bravo, provide that the practitioner will not submit any claim under this title for any item or service to any beneficiary and will not receive any reimbursement or amount described in paragraph 1, Bravo, for any such item or service during the 1-year period beginning on the date the affidavit is signed, and Charlie, be filed with the secretary no later than 10 days after the first contract to which such affidavit implies it is entered to. So now I'm like confused because I was kind of my train of thought went 2 ways. Contract and I'm kind of confused why that's there. So it's saying like if you enter in contract with somebody to provide service that okay. This is just saying if you agree to provide some kind of service, you can't, like an external contract, then you can't claim the reimbursement from it. Okay. 3, enforcement. If a physician or practitioner signing an affidavit described in paragraph 2 knowingly and willfully submits a claim under this title for any item of service provided during the 1-year period described in paragraph 2, Bravo, receives any reimbursement or amount described in subsection alpha 2 for any such term of service with respect to such affidavit. Alpha, this subsection shall not apply with respect to any items and services provided by the physician or practitioner pursuant to any contract on and after the date of such submission and before the end of such period. And Bravo, no payment shall be made under this title for any item or service furnished by the physician or practitioner during the period described in Clause 1. and no reimbursement or any payment of any amount described in subsection Alpha 2 shall be made for any such item or service. So I guess like what this all really is good for talking about is saying, so everybody's provided the same coverage. Well, nobody can go kind of around that and work out a deal like, oh, I'll pay you X amount of dollars if you treat me ahead of time of somebody else. I think that's what this is, something meant to combat. Okay, let's see. Okay, Title 4, Administration, Subtitle Alpha, General Administration Provisions. General duties of this, so Alpha, Section 401, Administration, Alpha, General duties of the Secretary. 1. In general, the Secretary shall develop policies, procedures, guidelines, and requirements to carry out this act, including related to Alpha, eligibility for benefits. 2. Bravo, enrollment. Charlie, benefits provided. Delta, provider participation, standards and qualifications as described in Title 3. Echo, levels of funding. Foxtrot, methods for determining amounts of payments to providers of covered services consistent with Subtitle Bravo. Golf, the determination of medical necessity and appropriateness with respect to coverage of certain services. Hotel, planning for capital expenditures and service delivery. India, planning for health and professional education funding. Julia, encouraging states to develop regional planning mechanisms. And Kilo, other regulations as necessary to carry out the purposes of this act. So this is all just saying, hey, you're the secretary. All this shit's your job. Okay, 2. Regulations. Regulations authorized by this act shall be issued by the Secretary in accordance with Section 553 of Title 5 of the United States Code. Okay, Bravo. Uniform Reporting Standards, Annual Report, and Studies. 1. The Uniform Reporting Standards. In general, Alpha, in general, Secretary shall establish uniform state reporting requirements and national standards to ensure that an adequate national database containing information pertaining to health services practitioners, approved providers, and the cost of facilities and practitioners providing such services, the quality of such services, the outcome of such services, and the equity of health among population groups. Such standards shall include, to the maximum extent feasible without compromising patient privacy, health outcome measures, and to the maximum extent feasible without excessively burdening providers, the measures described in subparagraphs Delta through Foxtrot of subsection Alpha 1. Then that was all. So Delta through Foxtrot was the job requirements part. That's what I was talking about in the previous section. Bravo reports. The Secretary shall regularly analyze information reported to it and shall define rules and procedures to allow researchers, scholars, healthcare providers, and others access to analyze data for purposes consistent with quality and outcomes research without compromising patient privacy. So this, the important thing here is that they're aggregating information to see what works, but they're not allowing your privacy to be violated, which is good because we already have things like Facebook to do that, and 2, to make sure that the doctors don't get overburdened with trying to make reports. And that's going to tie into the thing I want to talk about at the end. How long have we been going? An hour already. Alrighty. An hour, and we are just under halfway through. Okay, 2. Annual report. Beginning January 1st of the second year, beginning after the effective date of this act, the Secretary shall annually report to Congress on the following. Alpha, the status of the implementation of this act. Bravo, enrollment under this act. Charlie, benefits under this act. Delta, expenditures and financing under this act. Echo, cost containment measures and achievements under this act. Foxtrot, quality assurance. Gulf, healthcare utilization patterns, including any charges attributable to the program. Hotel, changes in the per capita cost of healthcare. India, differences in health status of populations of the different states, including income and racial characteristics and other population health inequities. I just want to take a second and go back to the hotel one. Changes in per capita cost of healthcare. That's something very good to keep track of, because, like I was saying before, rather than I don't like putting flat rates in legislature because things change, inflation, deflation. Okay, left India. Juliet, progress on the quality and outcome measures and long-range plans and goals for achievement in such areas. Kilo, necessary changes in the education of health personnel. Lima, plans for improving service in medically underserved populations. Mike, transition problems as a result of the implementation of this act. And November, opportunities for improvements under this act. So that's a lot of data that gets reported to Congress every year to basically see how things are working, and then we can make changes on as we need to, which is good. Okay. 3. Statistical analysis and analyses and other studies. The Secretary may, either directly or by contract, Alpha, make statistical and other studies on a nationwide, regional, state, or local basis of any aspect of the operation of this Act. Bravo, develop and test methods of payment and delivery as it may consider necessary or promising for the evaluation or for the improvement of the operation of this Act. And Charlie, develop methodological standards for evidence-based policy making. Okay, it's all pretty good there. Charlie, audits. 1. In general, the Comptroller General of the United States shall conduct an audit of the Board every 5th fiscal year following the effective date of this Act to determine the effectiveness of the program in carrying out the duties under subsection Alpha. 2. The reports. The Comptroller General of the United States shall submit a report to Congress concerning the results of each audit conducted under this subsection. That's just oversight and audits. Section 402, consultation. The Secretary shall consult with federal agencies, Indian tribes, urban Indian health organizations, and private entities such as professional societies, national associations, nationally recognized associations of experts, medical schools, and academic health centers, consumer and patient groups, and labor and business organizations in the formulation of guidelines, regulations, policy initiatives, and information gathering to ensure the broadest and most informed input in the administration of this Act. Okay, that sounds on its face pretty good. Nothing in this Act shall prevent the Secretary from adopting guidelines developed by such private entity if, in the Secretary's judgment, such guidelines are generally accepted and reasonable and prudent and consistent, or generally accepted as reasonable and prudent and consistent with this Act. Okay. Section 403, Regional Administration. Alpha, in coordination with regional offices, the Secretary shall establish and maintain regional offices to promote adequate access to and the efficient use of tertiary care facilities, equipment, and services. Wherever possible, the Secretary shall incorporate regional offices of the Centers for Medicare and Medicaid Services for this purpose. Bravo, appointment of regional and state directors. In each such regional office there shall be 1. A regional director appointed by the Secretary, 2. For each state and the region, a deputy director, and 3. 1 deputy director to represent the Native American and Alaska Native tribes of the region. That's good. Charlie, regional office duties. Regional offices shall be responsible for 1. Providing an annual state health care needs assessment report to the Secretary after a thorough examination of health needs in consultation with public health officials, clinicians, patients, and patient advocates. 2. Recommending changes in provider reimbursement or payment for delivery of health services in the states within the region. 3. Establishing a quality assurance mechanism in the state to ensure that in order to minimize both underutilization and overutilization, and to ensure that all providers meet high quality standards. Okay, so making sure everything is used properly. Section 404, Beneficiary Ombudsman. Alpha, in general, the Secretary shall appoint a beneficiary ombudsman who shall have expertise in the fields of healthcare and education of and assistance to individuals entitled to benefits under this Act. Bravo, duties. The beneficiary ombudsman shall 1. Receive complaints, grievances, and requests for information submitted by individuals entitled to benefits under this Act with respect to any aspect of the Universal Medicare program. 2. Provide assistance with this respect to complaints, grievances, and requests referred to in subparagraph Alpha, including Alpha, different Alpha. So including assistance in collecting relevant information for such individuals to seek an appeal of a decision or determination made by regional office secretary, and Bravo's assistance in such individuals in presenting information under relating to cost sharing. And 3. Submit annual reports to Congress and Secretary that describe the activities of the office that include such recommendations for improvement in the administration of this Act as the Ombudsman determines appropriate. The ombudsman shall not serve as an advocate for any increases or payments or new coverage of services, but may identify issues and problems with payment and coverage policies. So this is establishing the person you do all your bitching and griping to, and they turn around and say to Congress, hey, people are complaining that this is fucked up. Section 405, complementary conduct of related health programs. In performing functions with respect to health personnel, education and training, health research, environmental health, disability insurance, vocational rehabilitation, the regulation of food and drugs, and all other matters pertaining to health, the Secretary shall direct the activities of the Department of Health and Human Services toward contributions to the health of the people complementary to this act. And we are halfway through the document. And I need a drink of water. Oh God, what happened now? Okay. Something happened. I didn't stop the video. That's good. Okay. Subtitle Bravo, Control over Fraud and Abuse. Section 411, Application of Federal Sanctions to all fraud and abuse under the Universal Medicare Program. The following sections of the Social Security Act shall apply to this act in the same manner as they apply to the state medical assistance plans under Title 19 of such act. Section 1128, relating to the exclusion of individuals and entities. Section 1128 Alpha, civil monetary penalties. Section 1128 Bravo, criminal penalties. Section 1124, relating to the disclosure of ownership and related information. Section 1126, relating to disclosure of certain owners. Okay, Title 5, Quality Assessment. Here's where this would be interesting. Section 501, Quality Standards. Alpha, in general, all standards and quality measures under this act shall be performed by the Center for Clinical Standards and Quality of the Centers for Medicare and Medicaid Services, referred to in this title as the Center, in accordance with the Agency for Healthcare Research and Quality and other offices of the Department for Health and Human Services. Bravo, duties of the Center. The Center shall perform the following duties. 1. Practice guidelines. The Center shall review and evaluate each practice guideline developed under Part Bravo of Title IX of the Public Health Services Act. The Center shall determine whether the guideline should be recognized as a national practice guideline. That's pretty straightforward. 2. Standards of quality, performance measures, and medical review criteria. The Center shall review and evaluate each standard of quality, performance measure, and medical review criterion developed under Part Bravo of Title IX of the Public Health Service Act, 42 U.S.C. 29, et sequitur. The Center shall determine whether the standard, measure, or criterion is appropriate for use in assessing or reviewing the quality of such services provided by healthcare institutions or healthcare professionals. In evaluating such standards, the Center shall consider the evidentiary basis for the standard and the validity, reliability, and feasibility of measuring the standard. Okay, that's pretty straightforward. Where to look to set their quality standards. The profiling of patterns of practice, identification of outliers. The Center shall adopt methodologies for profiling the patterns of practice of healthcare professionals and for identifying and notifying outliers. Okay. 4. Criteria for entities conducting quality reviews. The Center shall develop a minimum criteria for competence for entities that can qualify to conduct ongoing and continuous external quality reviews in the administrative regions. Such criteria shall require an entity to be administratively independent of the individual or board that administers the region and shall ensure that such entities do not provide financial incentives to reviewers to favor one pattern of practice over another. The Center shall ensure coordination by reporting the Center shall ensure such coordination and reporting by such entities to ensure national consistency and quality standards. Okay, so basically they're saying that they can't skew the results, or they have to make sure that somebody didn't say, hey, this method is better than the other, and at least we think so, and we'll pay you to say that. 5. Reporting. The Center shall report to the Secretary annually, specifically on findings from outcomes of research and development practice guidelines that may affect the Secretary's determination of coverage of services under Section 401 Alpha 1 Gulf. Okay, Section 502, addressing healthcare disparities. Alpha, evaluating evaluating data collection approaches. The Center shall evaluate approaches for the collection of data under this Act to be performed in conjunction with existing quality reporting requirements and programs under this Act that allow for the ongoing, accurate, and timely collection of data on disparities in healthcare services and performance on the basis of race, ethnicity, gender, geography, or socioeconomic status. In conducting such evaluation, the Secretary shall consider the following objectives. 1. Protecting patient privacy. 2. Minimizing the administrative burdens of data collection and reporting on the providers under this Act. 3. Improving universal Medicare program data on race, ethnicity, gender, geography, and socioeconomic status. So this is again kind of like before. Get the data, make sure people's privacy is protected, make sure everything works, but don't burden all the providers with trying to get data all the fucking time. Because the more they're sending data to you, the less they're generating data by treating people. Bravo reports to Congress. 1. Report on evaluation. Not later than 18 months after the date on which benefits first become available as described in Section 106 Alpha, the Center shall submit to Congress and the Secretary a report and evaluation conducted under subsection Alpha. Such report shall take into consideration the reports of such evaluation. Alpha. Identify approaches, including defining methodologies for identifying and collecting and evaluating data on healthcare's disparities on the basis of race, ethnicity, gender, geography, or socioeconomic status under the Universal Medicare program. And Bravo, include recommendations on the most effective strategies and approaches to reporting quality measures as appropriate on the basis of race, ethnicity, gender, geography, or socioeconomic status. So find out if people aren't getting treated the same way and their needs aren't being met, find out why. And give an idea how to identify it. 2. Report on data analyses. Not later than 4 years after the submission of the report under subsection Bravo 1 and 4 years thereafter, the Center shall submit to Congress and the Secretary a report that includes recommendations for improving the identification of healthcare disparities based on the analysis of data collected under subsection Charlie. And Charlie, implementing effective approaches. Not later than 2 years after the date on which benefits first become available as described in Section 106 Alpha, the Secretary shall implement the approaches identified in a report submitted under subsection Bravo 1 for the ongoing, accurate, and timely collection and evaluation of data on healthcare disparities on the basis of race, ethnicity, gender, and geography, or socioeconomic status. Okay. Title 6, Health Budget Payments, Cost Containment Measures. Cost Containment Measures. Subtitle A, Budgeting. Section 601. So this is how we're going to pay for it. Section 601, National Health Budget. Alpha, the National Health Budget. 1. In general, by not later than September 1st of each year, beginning with the year prior to the date on which benefits first become available as described in Section 106 Alpha, the Secretary shall establish a national health budget, which specifies the total expenditures to be made for covered health care services under this Act. 2. Division of budget into components. In addition to the cost of covered health services, the national health budget shall consist of at least the following components. Alpha, quality assessment activities under Title V. Bravo, health professional educational expenditures. Charlie, administrative costs. Delta, innovation including in accordance with Section 1115 Alpha of the Social Security Act is 42 U.S.C. 1315 Alpha. Echo, operating and other expenditures not described in subparagraphs Alpha through Delta, referred to in this Act as the operating component. So those last four that just listed off are going to be referred to again, and they're called the operating component, consisting of amounts not included in other components. Foxtrot, capital expenditures, golf, prevention, and public health activities. 3. Allocation among components. The Secretary shall allocate the budget among the components in a manner that Alpha ensures fair allocation for quality assessment activities, and Bravo ensures the health professional education expenditure component is sufficient to provide for the amount of health professional education expenditures sufficient to meet the need for the covered health care services. So make sure we're paying to have all the stuff that we need. 4. Temporary worker assistance for up to 5 years following the date on which benefits first become available, as described in Section 106 Alpha. Up to 1% of the budget may be allocated to programs providing assistance to workers who perform functions in the administration of the health insurance system and who may experience economic dislocation as a result of the implementation of this act. That's good. So what it's saying, so basically, if all the health insurance companies going to go out to business, for 5 years, a certain amount of money is going to be set aside to for all the people that are going to lose their jobs if health insurance goes away. So that's good. Well, it's good, and that but also ties into the thing I want to talk about after I read all this. So, 5. The reserve fund. The secretary shall establish and maintain a reserve fund to respond to the cost of treating an epidemic, pandemic, natural disaster, or other such health emergency. Yep, that's definitely something we're going to need to do. Bravo. Definitions. In this section, 1. Capital expenditures. The term capital expenditures means the expenditures for which the purchase, lease, construction, or renovation of capital facilities for equipment and includes return on equity capital. 2. Healthcare professional education expenditures. The term health professional education expenditures means expenditures in hospitals and other healthcare facilities to cover costs associated with teaching related research activities. So it was just defining things that they talk about. Subtitle Bravo, Payments to Providers. Section 611, Payments to Institutional and Individual Providers. Alpha, Application of Payment Process under Title 18. Except as otherwise provided in this section, the Secretary shall establish, by regulation, fee schedules that establish payment amounts for benefits under this Act in a manner that is consistent with processes for determining payments for items and services under Title 18 of the Social Security Act, 42 U.S.C. 1395 et sequitur, including the application and provisions, including the applications of the provisions of and amendments made by Section 612. Yeah, this is something I'm going to have to talk about. Bravo, application of current plan payment reforms. Any plan payment reforms, activities, or demonstrations planned or implemented with respect to such Title 18 as of the date of the enactment of this Act shall apply to benefits under this Act, including any reform activities or demonstrations planned or implemented under the provisions of or amendments made by the Medicare Access and Chip Reauthorization Act 2015, Public Law 114, Tac 10, and the Patient Protection and Affordable Care Act, Public Law 111, Tac 148. Let me read this part too before I get into what I wanted to say. Section 612, ensuring accurate evaluation of services under the Medicare physician fee schedule. Alpha, standardized and documented review process. Section 1848 Charlie 2 of the Social Security Act, 42 U.S.C. 1395 Whiskey Tac 4 Charlie 2 is amended by adding at the end the following new subparagraph. Papa, standardized and documented review process. 1. In general, not later than 1 year after the date of enactment of the subparagraph, the Secretary shall establish, document, make publicly available a standardized process for reviewing the relative values of physician services under this paragraph. So this is saying, put in the Social Security Act, make it publicly available, how much it costs to do a treatment. 2. Minimum requirements. The standardized process shall include, at a minimum, methods and criteria for identifying services for review, prioritizing the review of services, and reviewing the stakeholder recommendations, identifying additional resources to be considered during the review process. That's the whole minimum standards thing. Minimum, it says at the beginning, minimum requirements is basically what's cut and dry. Okay, so those are the changes to the Social Security Act. Now, Bravo, planned and documented use of funds. Section 1848 Charlie 2 Mike of the Social Security Act, 42 U.S.C. 1305 Whiskey Tac 4 Charlie 2 Mike is amended by adding at the end the following new clause. X-ray, planned and documented use of funds. For each fiscal year, beginning with the first fiscal year after the first fiscal year beginning on or after the date of the enactment of this clause, the Secretary shall provide the Congress a written plan for using the funds provided under Clause 9 to collect and use information on physician services in the determination of relative values under this subparagraph. So that's amending amending the Social Security Act to say that the Social Security Secretary has to write to Congress about how to use funds for to pay for physician services. Okay, and then we have Charlie, internal tracking of reviews, and they're not getting. Okay, internal tracking reviews. 1. In general, not later than 1 year after the date of enactment of this Act, the Secretary shall submit to the Congress a proposed plan for systematically and internally tracking its review of the relative values of physician services, such as by establishing an internal database under Section 1848, Charlie 2 of the Social Security Act, 42 U.S.C. 1395, Whiskey Tac 4, Charlie 2, as amended by this section. 2. Minimum requirements. The proposal shall include, at a minimum, plans and a timeline for achieving the availability to systematically and internally track the following. Alpha, when, how, and by whom services are identified for review. Bravo, when services are reviewed and when the new services are added. Charlie, the resources, evidence, data, and recommendation used in reviews. Delta, when relative values are adjusted. E, Echo, the rationale for final relative value decisions. So, timeline for how to identify all these different ways of doing reviews. Okay, Delta, frequency of review, Section 1848, Charlie 2 of the Social Security Act, 42 U.S.C. 1395, Whiskey Tac 4, Charlie 2 is amended. 1. In subparagraph Bravo 1 by striking 5 and inserting 4. And I'm not going to go through the Social Security Act. You can look at this yourself. Let's see, 2 in subparagraph Kilo 1 by striking periodically and inserting annually. Yeah, okay, whatever. I'm not going to look that up. Echo, consultation with Medicare Payment Advisory Commission. In general, Section 1848, Charlie 2 of Social Security Act, 42 U.S.C. 1395, Whiskey Tac 4, Charlie 2 is amended. Alpha in subparagraph Bravo 1 by inserting in consultation with the Medicare Payment Advisory Commission after the Secretary, and Bravo in subparagraph Kilo 1.1 as amended by subsection Delta 2 by inserting in coordination with Medicare Payment Advisory Commission after annually. Okay, so that's, yeah. 2 conforming amendments. You know what, I'm not, let's see. Well, I'll read it anyways, just in case there's something worthwhile there. Conforming amendments. Section 1805 of the Social Security Act, 42 U.S.C. 1395, Bravo Tac 6 is amended. Alpha in subsection Bravo 1 Alpha by inserting the following before the semicolon at the end, and including and coordinating with the Secretary in accordance with Section 1848, Charlie 2, to systematically review the relative values established for physician services, identify potentially misvalued services, and propose adjustment to the relative values for physician services. And Bravo in subsection Echo 1 in the second sentence by inserting or the ranking minority member after the chairman. Okay, so that's just adding in about evaluating the money that's spent out. Okay, Foxtrot, periodic audit by the Comptroller General. Section 1848, Charlie 2 of the Social Security Act, 42 U.S.C. 1395, Whiskey Tac 4, Charlie 2 is amended by the subsection Alpha, as amended by subsection Alpha, is amended by adding at the end the following new subparagraph. Quebec, periodic audit by the Comptroller General. 1. In general, the Comptroller General of the United States, in this subparagraph referred to as the Comptroller General, shall periodically audit the review by the Secretary of relative values established under this paragraph for physician services. 2. Access to information. The Comptroller General shall have unrestricted access to all deliberations, records, and non-proprietary data related to the activities carried out in this paragraph under this paragraph in a timely manner upon request. Okay, yeah, whatever. All right, so the thing I wanted to talk about with this whole section, like paying physicians and everything, the one thing I don't see in here, at least not yet, it may come in later, but I don't think so, is there's an issue with Okay, so the basic idea is the value of a dollar is not the same across the United States. So to say that this is what's going to be paid to a physician for this procedure, to a physician or a provider for this procedure, um, no matter where you are in the country, it can be problematic because you have areas with higher cost of living than the other. So this section doesn't take that into account, at least not explicitly. There are parts in here where I can see, okay, it's kind of implied, but yeah, that's something I would want to have a further look taken. And so rather than just setting prices, because it seems like it's, like I said, it seems like it's just saying, okay, you have this procedure done in the United States, or if you're doing this procedure, this is what you're getting paid, and that can cause issues. So if there was an additional clause in there for adjustments made per cost of living, per area, then that would be better. Okay, Section 613, Office of Primary Healthcare. Alpha, in general, there is established within the Agency for Healthcare Research and Quality an Office of Primary Healthcare, responsible for coordinating with the Secretary, the Health Resources and Services Administration, and other offices in the department as necessary in order to 1. Coordinate health professional education policies and goals in consultation with the Secretary to achieve the national goals specified in subsection Bravo. The part that will come up. 2. To develop and maintain a system to monitor the number and specialties of individuals through their health professional education, any postgraduate training and professional practice. 3. Develop, coordinate, and promote policies that expand the number of primary care practitioners, registered nurses, mid-level practitioners, and dentists. And 4. Recommend appropriate training, educational, technical assistance, and patient advocacy enhancements of primary care health professionals, including registered nurses, to achieve uniform, high-quality patient safety. Okay, so this is good. So this is making sure that, one thing we don't have a lot of in this country, as I understand it, is we don't have a whole lot of primary health care providers. So it mentions that. But the main idea is to make sure that not all one people are, basically incentivize people to, or will make sure that you're hiring, or you're not hiring, but the idea is that you want enough people to suit every need. And this is trying to promote that. So the national goals, Bravo, national goals. Not later than 1 year after the date of enactment of this act, the Office of Primary Health Care shall set forth national goals to increase access to high-quality primary health care, particularly in underserved areas and for underserved populations. Section 614, payments for prescription drugs and approved devices and equipment. Alpha, negotiated prices. The prices to be paid for covered pharmaceuticals, medical supplies, and medically necessary assistive equipment shall be negotiated annually by the Secretary. Bravo, prescription drug formulary. 1. In general, the Secretary shall establish a prescription drug formulary system which shall encourage best practices in prescribing and discourage the use of ineffective, dangerous, or excessively costly medications when better alternatives are available. Opiates. Sorry there. 2. Promotion of use of generics. The formulary under this subsection shall promote the use of generic medications to the greatest extent possible. 3. Formulary updates and petition rights. The formulary under this subsection shall be updated frequently, and clinicians and patients may petition the Secretary to add new pharmaceuticals or to remove ineffective or dangerous medications from the formulary. And for the use of off-formulary medication, the Secretary shall promulgate rules regarding the use of off-formulary medications which allow for patient access but do not compromise the formulary. Okay, so what they're saying is that there's going to be, it's basically saying, okay, prefer you to use these medications, more likely generics. If in the rare instance that a patient needs a certain medication, we can allow for that also. Yeah, because for me myself, I don't respond to medication. It's either it's pretty interesting. Either medication doesn't really affect me at all, or it affects me too much. There's no happy medium. Title 7, Universal Medicare Trust Fund. 7 Section 01, Universal Medicare Trust Fund. Alpha, in general, there is hereby created on the books of the Treasury. Okay, here's where we get to where the paying for it. The Treasury of the United States, a trust fund to be known as the Universal Medicare Trust Fund, in this section referred to as a trust fund. The trust fund shall consist of such gifts and bequests as may be made, and such amounts as may be deposited in or appropriated to such trust fund as provided in this act. Ugh. Man, having nose hairs suck. Sucks. Yeah, grammar. Yeah. Okay. Bravo. Appropriations into trust fund. 1. Taxes. There are hereby appropriated to the trust fund for each fiscal year, beginning with the fiscal year, which includes the date on which benefits first become available, as described in Section 106, out of any monies in the Treasury not otherwise appropriated, amounts equivalent to 100% of the net increase in revenues to the Treasury, which is attributable to the amendments made by Sections 801 and 902. Okay, so we got to get to 801 and 902 to talk about where we're actually spending the money for this. The amounts appropriated by the preceding sentence shall be transferred from time to time, but not less frequently than monthly, from the general fund to the Treasury, in the Treasury to the trust fund. Such amounts to be determined on the basis of estimates by the Secretary of the Treasury of the taxes paid or deposited into the Treasury, and proper adjustments shall be made in amounts subsequently transferred to the extent prior estimates were in excess of or less than the amounts that should have been so transferred. Okay. So they're saying, yeah, you set up a trust fund and money's going to come out of taxes for that based on something that we haven't read yet. Current program receipts. Notwithstanding any other provisions of law, there are hereby appropriated in the trust to the trust fund for each fiscal year, beginning with the first fiscal year beginning on or after the effective date of benefits under Section 106, the amounts that would otherwise have been appropriated to carry out the following following programs: Alpha, the Medicare program under Title 18 of the Social Security Act, other than amounts attributable to any premiums under such title. Bravo, the Medicaid program under state plans approved under Title 19 of such act. Charlie, the Federal Employee Health Benefits Program under Chapter 89 of Title 5 of the United States Code. Delta, the TRICARE program under Chapter 55 of Title 10, United States Code. Echo, the Maternal and Child Health Program under Title 5 of the Social Security Act. Vocational Rehabilitation Programs, programs for drug abuse and mental health services under the Public Health Service Act. Programs providing general hospital or medical assistance, and any other federal program identified by the Secretary. In consultation with the Secretary of the Treasury, to the extent that programs provide for payment for health services, the payment of which may be made under this Act. Okay. Let's see. Restrictions shall not apply. 3. Restrictions shall not apply. Any other provision of law in effect on date of enactment of this Act restricting the use of federal funds for any reproductive health services shall not apply monies in the trust fund. Okay, that's good. So they can't say if there's something that's going to generate money for like anti-abortion stuff, it can't be used to fund the Medicare for All program. Well, not just anti-abortion, but like anything. So anything that restricts the people from using the why am I fucking blanking on the term now? Or basically, if you're pregnant, you go there. You know, the center's where you go if you're pregnant. Why am I fucking hate that when you just can't remember something. You feel like such an Okay. Oh, whatever. Charlie, incorporation of provisions. The provisions of this subsection of subsections Bravo through India of Section 1817 of Social Security Act 42 U.S.C. 1395 India shall apply to the trust fund under this section in the same manner as such provisions apply to the Federal Hospital Insurance Trust Fund under such section 1817, except that for the purposes of applying such subsections to this section, the Board of Trustees of the Trust Fund shall mean the Secretary. Delta, transfer of funds. Any amounts remaining in Federal Hospital Insurance Trust Fund under Section 1817 of the Social Security Act 42 U.S.C. 1395 India, or the Federal Supplementary Medical Insurance Trust Fund under Section 1841 of such Act 42 U.S.C. 1395 Tango, after the payment of claims for items and services furnished is under Title 18 of such Act have been completed, shall be transferred to the Universal Medical Trust Fund under this section. In Title 8, conforming amendments to the Employee Retirement Income Security Act of 1974. Oh, I gotta see something really quick. I'll put that there. Oh. I need a new body. Because these glasses I got are new and they seem a little bit different and not in a good way. Yeah, okay. Where the fuck did I leave off? Okay, Title 8, conforming amendments to the Employee Retirement Income Security Act of 1974. You know what, oh wait, I gotta read that because they talk about this. Okay, Section 801, prohibition of employee benefits duplicative of benefits under the Universal Medicare Program, coordination in case of workers' compensation. Alpha, in general, Part 5 of Subtitle Bravo of Title 1 of the Employee Retirement Income Security Act of 1974, 24 U.S.C. 1131 et sequitur, is amended by adding to the end of the following new section. I'm just going to look through this really quick. It's just preventing people from double dipping, basically. So, preventing workman's comp paying for the same thing that Medicare for All pay for. Okay. Let's see. Section 802, repeal of continuation coverage requirements under ERISA, whatever ERISA is. I'm not sure what that is. And certain other requirements. Alright, I'm just going to skip that. Title 9. Additional conforming amendments. Section 901, relationship to existing federal health programs. Medicare, Medicaid, and state children's health insurance programs, S-CHIP. 1. In general, notwithstanding any other provision of law, subject to paragraphs 2 and 3. Alpha, no benefits shall be available under Title 18 of Social Security Act for any item or service furnished beginning on or after the effective date of benefits under Section 106 Alpha. Bravo, no individual is entitled to medical assistance under a state plan approved under Title 19 of such act for any item of such or service furnished on or after such date. Charlie, no individual is entitled to medical assistance under state child health plan under Title 21 of such act for any item or service furnished on or after such date. And Delta, no payment shall be made to a state under Section 1903 Alpha or 2105 Alpha of such act with respect to medical assistance or child health for any item or service furnished on or after such date. So saying that people, so it's basically removing eligibility because most likely because the Medicare for all is transition in the case of inpatient hospital services and extended care services during a continuous period of stay, which began before the effect. So this is all basically transitioning stuff to transitioning the other stuff to the Medicare for all, because they don't need to be covered and they don't need to be there anymore because the Medicare for all will take care of everything. Title 10, transition. Subtitle A, Alpha, transitional Medicare buy-in option and transitional public option. So this, because this video, we're getting close to 2 hours now, so I'm just going to go through this and just kind of scan this. So this part right here is pretty much like I said before. It's reduces the age that Medicare covers. Every individual paragraph 3. As long as you're a resident, so as long as you're a resident here, or you're a nationalized citizen, or you're an alien lawfully admitted for permanent residence, you get covered basically. The individual has attained equitable years of age, not attained 65 years of age. Okay, so what this is doing is lowering the age by 10 years every year, and before it covers everybody. That's yeah. Amount of monthly premiums the Secretary shall, during September of each year, beginning 1st September following date of enactment of Medicare for All Act 2019, determine a monthly premium for all individuals enrolled under this section. Such monthly premium shall be equal to 1/12 of the annual premium computed under paragraph 2 Bravo, which is coming up. Shall apply with respect to coverage provided under this section for any month in the succeeding year. So the annual premium. Alpha, combined per capita average for all Medicare benefits. The Secretary shall estimate the average annual per capita amount for benefits and administrative expenses be payable under parts Alpha, Bravo, Delta, including as applicable under Part Charlie in the year for all individuals enrolled under this section. Bravo, the annual premium. Annual premium under the subsection for once in a year is equal to the average annual per capita. It's estimated under subparagraph Alpha for a year. Increased premium for Part C and D plans. Not eligible for cost sharing. Eligibility for premium assistance. Okay. So this looks all fairly standard. Nothing really here sticks out to me. Any United States resident may enroll in a Medicare transition plan. Coverage for benefits required to be covered under Title II. As any payment rate under this subsection for prescription drugs shall be at a rate negotiated by the administrator and with the manufacturer of the drug. If the administrator is unable to reach a negotiated agreement of reimbursement rate, the administrator shall establish a rate equal to lesser of the price paid by the Secretary of Veterans Affairs to procure the drug under laws administered by the Secretary of Veterans Affairs. Price paid to procure a drug under Section 8126 of Title 38 United States Code, or best price determined under Social Security Act for the drug. I'm not really interested in the transition part. So there's so it talks about here. So special rule for taxpayers enrolled in Medicare transition plan. So the percentage. So if you're at the poverty line, your percentage is 2. If up to 138% of the poverty line, your percentage is 2.04. The initial and final differ, so up to 158%, the initial amount is 3.06, the final is 4.08, and if you're above 150%, the initial is 4.08, and the final is 5%. Not bad. This is all transitional stuff. And yeah, I'm pretty sure the and the rest of this all transitions. Yeah. Private health. Yeah, miscellaneous. Up for supplemental. Okay, so Title 11 miscellaneous. Updating resource limits for supplemental security income eligibility (SSI). So here's changing amounts and So section 1611 alpha 3 of the Social Security Act 42 USC 1382 alpha 3 is amended, and subparagraph 1 and subparagraph alpha by striking and after January 1st, 1988, and Bravo by inserting and to $6,200 on January 1st, 2019 before the period. That doesn't tell me a whole lot. I'm actually looking it up. Okay, so yeah, I'm not going to read through the rest of the stuff. It's all those stuff. Okay. So, apparently my glasses are not that great. The new ones I just got, which is great. So overall, it seems okay. So let's get to the stuff that I wanted to talk about. I've talked about in another video about hunting period, right? So, first off, my thing is, I would, oh God, I need to stretch after all that. I would prefer to see a more socialized system. I would prefer to see hospitals in control, or hospitals being controlled by individual counties or large cities, and generic drug manufacture being done by government institutions, which is, So personally, I would prefer, every city, every big city, every country, every county has their own hospital, and the federal government pays them. Again, I raised the argument of why am I feeding to corporate profits something, using a public service to feed corporate profits. That's my issue. Now to the hunting thing. So you hear a lot in these other countries, the word in these other countries. Oh, you go to the institute a social health care system, and now it takes forever. Blah blah blah. So let's talk about that. So I'm a veteran. I'm a disabled veteran. I gotta wait a long time for hospital appointments, or even to see my primary care provider or whatever. Right now, I'm in the middle of waiting 6 weeks for something that most people would have to wait a week at most for. So I have firsthand knowledge of the level of suck that it can be for a public service. The situation other people are complaining about. However, nobody wants to bring to mind the idea when they mention that talking point is how well are these institutions funded? Okay, as you all know, the VA has all kinds of issues all around the country. Personally, I live in New Jersey, which the VA hospitals around here tend to be better, or at least not as shitty as places in the rest of the country. But they still have their problems, especially with understaffing. And yet, despite that, I would still rather move to a more socialized system, because I would rather not only move to a more socialized system, I would want to move to a well-funded socialized system. There's a distinction there, making sure that we are paying into the pool and paying enough for people to actually want to do these jobs. And if we have enough people that want to do these jobs because we're paying people enough, then it's, we all get our treatments on time. Now, the transition period and everything like that. So if we just open the floodgates and everybody goes to the doctors, and you're going to wind up waiting forever just for your case, and then it's going to be the same situation where people are, how do you pick priority? So resources have to be divided to pick priority, if you're going to do that, or first come, first serve, or whatever. And it's just going to be, there's no way in transitioning that isn't going to be, this is going to have some level of suck in it, which is basically what I'm trying to get to. And I know that guy, they had a guy that was like, oh, my condition is, I feel bad for the guy. He had to use a thing to talk in Congress, but, I'm going to tell you right now, I'm not here to score brownie points with anybody. I don't care who you are, rich, poor, healthy, sick, whatever. I'm just going to tell you exactly how it is. Yeah, it sucks. I know it sucks. But you're one person, and there's millions of people in this country. And I'll tell you that straight to your face. Okay? Because I've had to deal with that myself. And yeah, sure, I'm not as bad off as that guy is in many ways. But I got my own problems to deal with. And that's just how it is. So the one thing, so if we do move to a more socialized healthcare system, that is something we're going to see for, I would say, at least a decade, about a decade. Is long wait times, because you get all these people that haven't had their conditions taken care of, all of a sudden they can have them taken care of, and it's going to take some time for everybody to get taken care of, and things are going to be backlogged and whatnot. And if it means we're waiting a little bit longer, I don't mind waiting a little bit longer, because in the long run, as long as we're analyzing and we keep streamlining the process and meeting everybody's needs adequately so they don't have to keep going back, then eventually we'll take care of the problems, and then it'll just be a normal situation where, oh, I got to go see my primary care doctor, and I'll call him up and, okay, I got an appointment, this Friday, or, early next week or whatever, and that's that. So that was the one thing that I wanted to talk about, because I don't think people talk about this that much. They just say, oh, socialized healthcare to wait forever. It's not that simple. So yeah, overall the bill is not a bad bill. Yeah, that's pretty much it. So hope you got something out of the 2 hours of me reading things and then finally saying, fuck it, I don't want to read anymore. I hope you understand the situation, why I think things should be done in a certain way, and what to expect from this kind of bill going through, or if it does go through, and why to expect those things. So there you have it. I'm going to stretch and rest my voice.